Hello, John Rose here and welcome back. A big happy new year to all my subscribers. There's nearly 20,000 of you now, which is absolutely awesome, and I hope this will grow over the next year. If you haven't subscribed, it's a good opportunity to do so because there's going to be loads of interesting content over the next year, including a 10-part series covering most aspects of endodontics. In this video presentation, I'm looking at retreatment. It's a maxillary molar that's been obturated with GP, but there's a fractured instrument in one of the root canals. And I'm going to show you a simple but predictable technique for removing fractured instruments using ultrasonics and a loop. I hope you enjoy it, and I'll see you again soon. Here you can see the preoperative radiograph of the maxillary right first molar. The tooth was symptomatic and there's a periapical radiolucency over the MB root. Closer inspection of the preoperative radiograph shows that the crown is a poor fit. There's a marginal defect with the ledge and caries in this area. The access cavity appears to have been filled with restorative material, however it's not clear whether the root canals are obturated with paste or gutta perca. There's a fractured file in the palatal root, and this doesn't seem to follow the path of the root canal. It seems to be jammed into the wall and the root canal has been ledged. Small volume CBCT is an excellent way of identifying the piece of fractured instrument and also reveals that the MB2 canal has been missed. Obviously in this case the crown has to be removed. There's a marginal defect and caries underneath. Restorative material in the access chamber has been removed using a long tapered diamond, and I'm now removing caries in the remaining material with a large LN burr. Looking at the floor of the pulp chamber, you can see the root filling material, which is a mixture of GP and an endomethasone paste. The obturating material is removed to the level of the fractured instrument in the palatal canal using a Gates Glidden number 2. Here I'm flushing the root canal with 3% sodium hypochlorite before drying and inspecting under high microscopic magnification. You can see that I've removed material from around the head of the instrument and now it's clearly visible. It's time to give this some ultrasonic vibration with an Action ET25 tip, or in this case a Terrucci tip. So once you've gained access to the piece of instrument and loosened it with ultrasound, it's a matter of retrieving it. And this can be quite tricky, certainly if the instrument's around the curvature in the root canal. So we're going to use a loop, and there are lots of loops available on the market. Here are a couple, and we're going to use the Broken Tool Remover. It's a very simple device. It has a metal loop, very fine, that you can insert right down the root canal, loop it over the piece of fractured instrument, tighten it, and then retrieve it like a lasso. So keep watching and you'll see how it's done. I'm gently inserting the loop down the root canal and over the head of the piece of instrument that's fractured and has been loosened with ultrasound. I'm then going to tighten the loop using the button on the handpiece and gently retrieve the instrument from the root canal. Here you can see the piece of fractured instrument successfully retrieved from the root canal. I then continued with the routine root canal retreatment, cleaning and shaping all the other root canals, irrigating them thoroughly with 3% sodium hypochlorite, and then obturating them with a vertically compacted gutter-perker technique. That missed MB2 was located quite easily and had convergence with the MB1. So just to recap, here we have the preoperative radiograph showing the periapical lesion at the apex of the MB root and the fractured instrument in the palatal canal. Now the post-operative result with all the root canals retreated and well obturated, and a core fabricated using a dual cure composite ready for the dentist to place a new full coverage crown. This tooth will be reviewed in 6 months to check there's some bony healing around the apex of the MB root. Well, I do hope you enjoyed that presentation. Don't forget to hit the little subscribe button if you haven't already. Stay tuned because there's going to be loads of interesting content to come. Ask as many questions as you like and I'll try and answer all of them. And above all, enjoy your endo.